After having studied about bacterial causes of otitis externa, now let us look into the viral causes. The viral diseases viral otitis externa. In viral otitis externa, we have two conditions. One is the Ramsay Hunt syndrome or Herpes zoster Oticus, and second is hemorrhagic otitis externa. Let us look into both of them one by one. First is Herpes zoster Oticus, and this is also called as Ramsay Hunt syndrome. Now, what is Herpes zoster Oticus or Ramsay Hunt syndrome? It is basically an infection by Varicella zoster virus that belongs to the family of herpes viruses. And that Varicella zoster virus produces chickenpox, but the virus remains latent inside the geniculate ganglia. It remains latent for decades after chickenpox infection. And whenever the same person is undergoing any immunocompromised or a stressful state, then this virus will get reactivated and it produces symptoms. That is usually what happens with Varicella zoster virus. Now, when this Varicella zoster virus is lodged in geniculate ganglion is a sensory ganglion of the facial nerve, then it causes this Herpes zoster Oticus. So, this disease is characterized by an infection with Varicella zoster virus. The primary infection doesn't cause this. It is the secondary reactivation that happens years later as the Varicella zoster virus is lodged in the geniculate ganglion. It is in the dormant state, and whenever there is a stressor or an immunocompromised state, this virus gets reactivated and it causes symptoms, that is Herpes zoster Oticus or Ramsay Hunt syndrome. So first it is in the geniculate ganglion, it gets reactivated and then it travels via the course of the facial nerve. It affects the facial nerve and then it affects the inner ear, spiral and vestibular ganglia. And then even cranial nerves 5 and 8 can also be affected by this virus. So finally 5, 7 and 8. 7 is most important, it will always happen. And sometimes trigeminal nerve and 8th nerve can also get affected. Cochleovestibular nerve can also get affected. Now when this virus is reactivated, what it does is it produces herpetiform lesions. What are herpetiform lesions? They are vesicular eruptions. Vesicular eruptions are seen along the course of the facial nerve. So first initially the patient presents with, let us see the clinical features. The patient initially presents with severe ear pain, severe otalgia, and then this is followed by painful vesicles. With erythematous base. These vesicles have a red colored base. Where are they present? They are present in the ear canal, external auditory canal. On the pinna and also on the soft palate. Then the vesicles rupture to form bullae, and bullae are present on all these areas. And then along with these symptoms, there could be ipsilateral facial nerve palsy. And in about 25% of the patients, they experience vertigo, nystagmus, tinnitus, ringing sensation of the ear, and sometimes even hearing loss. What is the other function of the ear apart from hearing? It is vestibular function. Even the vestibular function is affected. If you perform a caloric test, the responses are either absent or decreased. So these features are seen in severe cases. Vestibulocochlear nerve involvement is there. If it is there, that produces vertigo, and even sensory neural hearing loss can also occur in those patients. Another variant of this is herpes zoster ophthalmicus, where the eye is affected. We are learning about herpes zoster Oticus. To summarize all these clinical features, please look into this picture. You can see vesicles on the pinna. These are all the vesicles that are present. Vesicles are present on the tongue and on the soft palate. They are actually present in the external auditory canal also. And this is a picture showing ipsilateral facial nerve paralysis. On one side, there is deviation of angle of mouth, and all these features are seen, which are features of facial nerve palsy. These are the clinical features of herpes zoster Oticus. Next, let us look into how we diagnose the case. Generally, clinical features are enough to understand that it is a case of herpes zoster Oticus, but still, we can perform a gadolinium enhanced MRI. Gadolinium provides contrast to the MRI. It improves the contrast, always improves the quality of the image, facilitates us to see better. So on a gadolinium enhanced MRI, we see that there is enhancement of the geniculate ganglion of facial nerve, where this virus was lying dormant and it has now become activated. This is seen in a gadolinium enhanced MRI. If at all we do a histopathological examination, herpes virus, Varicella zoster virus, shows multinucleated giant cells. And we can also see inclusion bodies, and those inclusion bodies are called as Cowdry type A. There are various types of inclusion bodies that are seen in viruses, and the inclusion body that is seen in this is Cowdry type A type of inclusion body. And this is an image of the histopathological examination, where clearly these multinucleated giant cells can be seen. This is an image showing herpes zoster and basically the multinucleated giant cells. Viruses cannot be seen under histopathological examination. Next, what we can do is we can detect the virus itself by doing a PCR of the Varicella zoster virus DNA. If we detect Varicella zoster virus DNA on the PCR, that confirms herpes zoster infection, reactivation. And we can also do serological tests. IgM and IgG antibodies can be assessed, and it shows whether the infection is active or passive immunity is present, and it can be used to diagnose herpes zoster infection. And another test that is done is the Zank test. This test is not routinely done, in that the vesicular fluid is analyzed, and in the vesicular fluid also we see multinucleated giant cells with Cowdrey type A inclusion bodies. That is the Zank test. Next, coming to the treatment part of this disease, as it is a viral condition, we use antiviral drugs. Valacyclovir is used. Valacyclovir 1 gram thrice a day can be used for about a week, and along with that, prednisolone can also be used. Prednisone is a steroid drug that is used to reduce the vesicular eruption and the intense pain that is caused by it. And patients who are in an immunocompromised state, or basically mostly in them, the herpes zoster virus gets reactivated. So in those conditions, for immunocompromised patients, we can directly use IV acyclovir. Acyclovir can be given by intravenous route. But the most important part of the treatment of herpes zoster is pain control. Because this pain is very severe, and we have to make sure that the patient's quality of life is not affected by it, because it causes pain during the course of the disease, and later on also as a complication of this, there arises a condition called post-herpetic neuralgia, which is very, very painful. So pain control becomes an integral part of the management of herpes zoster Oticus. So let us see how pain control is achieved. First, in case the patient is having just mild amount of pain, that's fine, we can use acetaminophen or any other regular NSAID, or we can use a mild opioid like tramadol. Okay, in case the patient is having moderate amount of pain, we can use a strong opioid such as oxycodone, or we can use nortriptyline, or we can use drugs that are used for nerve pain, that is gabapentin or pregabalin, and we can also use corticosteroids. These drugs, if the patient is having moderate amount of pain, moderate to severe amount of pain, these drugs will work. Now, as I told you, there can be a complication called as post-herpetic neuralgia. What is post-herpetic neuralgia? Even after all the vesicles have subsided and the disease has subsided, there is no active inflammation or any other process going on, but the nerves have been damaged. and that will result in their constantly causing pain to the patient, although there is no active disease. And this usually happens, it will usually persist for at least 3 months after herpes zoster or oticus has occurred in the areas wherever rash has occurred, because the nerves have been damaged. That is a sequelae, a complication of herpes zoster oticus. We call it post-herpetic neuralgia. And this is the most common complication that occurs in people who are aged, in people who are more than 50 years of age. This complication usually arises in them, and this pain will at least persist for 3 months, but it can go on for months to years also. And this it can be mild, or sometimes it can be very severe. Usually it is a burning, stabbing type of pruritic pain. The patient experiences burning, pruritic, sharp, and stabbing type of pain. It's very painful actually, and for that, for most of the patients, we have to again go for gabapentin or pregabalin, and that is the drug of choice for post-herpetic neuralgia. And along with that, we can also add tricyclic antidepressants. The drug of choice is pregabalin or gabapentin. We can also use tricyclic antidepressants as an add-on or as an alternative. Now, but as I said, this pain persists for months to years, and if at all the patient does not want to take oral medications, we can give capsaicin as the topical therapy. Topical therapy can be done by capsaicin. Okay, this can be used. The main concern is how to address the pain. Now, I will quickly summarize that for you again. Let me summarize the pain control again. If the patient is having mild to moderate pain, and if the patient is preferring a local therapy, we can use capsaicin cream or patch. Alternatively, we can use a lignocaine cream also. Now, know if the patient is having a severe amount of pain and if the patient is ready to take oral medication, then we can use gabapentin or pregabalin. If there is any contraindication to gabapentin, or if there is no response with gabapentin, then we can add amitriptyline. In case with that also there is no response, we can also give nortriptyline. With that also, if there is no response, then we can add anti-epileptic medications or serotonin norepinephrine reuptake inhibitors such as duloxetine and venlafaxine. There also, if there is no response, or if there is partial response with alternative therapy, we can add adjunctive therapy such as intrathecal glucocorticoids or opioid analgesics. Let me quickly summarize the pain management. In case the patient is having mild pain, acetaminophen, NSAIDs will do, or a mild opioid. In case the patient is having a moderate to severe pain, strong opioids such as oxycodone, or otherwise gabapentin or pregabalin and nortriptyline can be used. Even corticosteroids can be used. And for post-herpetic neuralgia, the drug of choice is pregabalin or gabapentin. Tricyclic antidepressants can be used as an alternative. And if the patient is not able to take oral medication, systemic therapy, then topical therapy with capsaicin cream can be used. This is about post-herpetic neuralgia. So let me quickly summarize herpes zoster oticus. It is caused by Varicella zoster virus, secondary reactivation of the Varicella zoster virus, which was lying dormant in the geniculate ganglion, the sensory ganglion of facial nerve. And this usually happens when there is a physical or a psychological stressor or during an immunocompromised state. So the virus gets reactivated in geniculate ganglion, spreads into the facial nerve, inner ear, and finally affects the spiral and vestibular ganglia also. And sometimes it can affect trigeminal nerve and cochleovestibular nerve also. In all those areas, it will cause vesicular eruptions. So the patient will have severe ear pain, and there are painful vesicles with erythematous basis, and these vesicles will later rupture to form bullae, and then there will be ipsilateral facial nerve palsy. And in 25% of the patients there can be vertigo, tinnitus, nystagmus, and hearing loss with vestibular function also being affected. Vestibular function is also affected. And for diagnosing this condition, we can perform a gadolinium enhanced MRI, which shows enhancement of the geniculate ganglion of facial nerve. And on a histopathological examination, we see multinucleated giant cells, and on a Zank smear, we can see again see these giant cells with Cowdrey type A inclusions. And to directly detect the virus, we can do a PCR of the Varicella zoster virus DNA, and we can also perform serological tests. And treatment consists of giving antiviral drugs, prednisolone, and in case of immunocompromised patients, IV acyclovir can be given. And pain control of these patients is very, very important to ensure a good quality of life for the patient. And now let us move on to the next condition caused by virus, and that is Otitis Externa hemorrhagica. Otitis Externa hemorrhagica. Otitis externa hemorrhagica is a viral infection, but sometimes it is also caused by Mycoplasma pneumoniae and Haemophilus influenza. These are atypical bacteria. Haemophilus influenza. So what exactly happens in Otitis externa hemorrhagica is, as the name itself suggests, there is formation of hemorrhagic bulla. Hemorrhagic bulla are formed on both the external auditory canal as well as the tympanic membrane, the lateral surface of tympanic membrane. Hemorrhagic bulla are formed, and predisposing factors for this are an upper respiratory tract and winter season. Summer season can cause diffuse otitis externa, and winter season predisposes to otitis externa hemorrhagica. So let us look into the clinical features of this condition. When there is inflammation, obviously there will be pain. Otalgia is there. And then there is hemorrhagic discharge. Why hemorrhagic discharge? Because there are hemorrhagic bulla, or sometimes even a serous discharge could be present. The bullae rupture and they give rise to hemorrhagic or serous ear discharge. And upon examination, we find hemorrhagic bullae in the external auditory canal, and when they rupture, that will result in a serous discharge. And along with it, a middle ear infection effusion can also be present, and sometimes this can lead to conductive type of hearing loss with a sensory neural element also is sometimes possible. So for this condition, how do we treat? Because there is severe amount of pain, we give analgesics for pain relief. To prevent secondary infections, antibiotics are also used. Although it is a viral condition, to prevent secondary infections, we can use antibiotics, or if there is a middle ear infusion, for that also antibiotics are used. Or when the bullae have ruptured, they are predisposed to bacterial infections, and antibiotics will prevent all those sequelae. We can use macrolide or quinolone antibiotics. Macrolides can be used, or fluoroquinolones can be used. And topically we can give antibiotics and steroids. To prevent bacterial superinfection and also to reduce the inflammation. We can give topical antibiotics and steroids, and the bullae should not be incised. Although if the bullae rupture, it causes pain relief. If they naturally rupture, that's okay, but we should not incise the bullae. This is about Otitis Externa hemorrhagica. Let me quickly summarize it. It is caused by Mycoplasma pneumoniae and Haemophilus influenzae. Hemorrhagic bullae are seen on the external auditory canal and also on the lateral surface of tympanic membrane. And clinical features, it's very simple. There is ear pain, hemorrhagic bullae are seen, and discharge is seen. Hemorrhagic or a serosanguinous discharge is seen. And for treatment, we give analgesics for pain relief and antibiotics, and topically also we give antibiotics and steroid creams. So these are the two conditions of viral etiology. One is Herpes zoster Oticus and second is Otitis Externa hemorrhagica. Thank you.